Hello, my name is Dr. Ulka Vaishampayan. I'm a professor of oncology at Rogel Cancer Center, University of Michigan in Ann Arbor. And today it's my pleasure to present to you the summary of the GU ASCO Symposium in 2022. One of the main highlights of this symposium was the ARASENS trial, which was reported as well as published in the New England Journal of Medicine the same day, which showed the overall survival of darolutamide in combination with docetaxel and androgen deprivation therapy was superior as compared to ADT and docetaxel only in metastatic hormone-sensitive prostate cancer population. So this was the phase 3 ARASENS trial report, reported by Matthew Smith being the lead author. And this is the study design, which shows you that this was a placebo-controlled double-blind trial with the primary endpoint of overall survival. Patients with metastatic HSPC were eligible who had not been treated previously, and darolutamide was given concurrently with docetaxel in this study. Multiple secondary endpoints are seen: time to castrate-resistant prostate cancer, time to pain progression, skeletal related events, etc., were also looked at, as well as toxicity profile. Here is the primary endpoint curve showing you overall survival was significantly improved with the addition of darolutamide to the combination of ADT and docetaxel. About 48-month survival is shown here, from improvement from 50% or so to 62.7%. Hazard ratio for death is 0.68, p-value is 0.001, which is statistically significant. Other subgroup analyses of de novo metastatic disease or recurrent metastatic disease also favors the darolutamide combination, and you can see the hazard ratios up here. Again, fairly significant data, which shows that regardless of whether patients have de novo or recurrent metastatic disease, ARASENS trial showed advantage for addition of darolutamide. Other key secondary endpoints: time to castrate-resistant prostate cancer, large magnitude of benefit as compared to the placebo arm, and time to pain progression, also there was an improvement. Other endpoints: time to first skeletal related event or time to subsequent antineoplastic therapy. Time to next treatment was, of course, significantly better, as darolutamide appeared to give sustained longer-term control as compared to ADT and docetaxel. So overall survival benefit has been seen with treatment intensification in two separate trials now currently, with piece one being reported back in ASCO 2021. Median follow-up was 52.8 months for that study, and that included ADT, docetaxel, and abiraterone plus prednisone. Median survival has not been reached as compared to 52.8 months on the control arm. Here in the ARASENS trial, also significant results with the addition of darolutamide to ADT plus docetaxel, same control arm in both of these studies. And median survival, again, is not reached yet with the darolutamide arm, and 48.9 months. So consistent survival was noted in the control arms across the two studies. Take-home message from this study is, of course, that triplet regimen with ADT, docetaxel, and darolutamide represents the new standard of care in men with metastatic hormone-sensitive prostate cancer. Patient characteristics to consider for a combination therapy approach include both M1B and M1C disease stage, so whether they were de novo metastatic disease presentation or recurrent after biochemical relapse progressing to metastatic stage, and of course fitness for combination treatment. But treatment intensification in metastatic HSPC is now evolved as the current standard. It is important and clearly has survival benefit. The addition of darolutamide is very well tolerated and is feasible. The question of whether ADT plus darolutamide only without the docetaxel will be beneficial is currently under investigation. And at this point, the triplet regimen definitely holds a significant advantage for our patients with metastatic prostate cancer. Next, we will discuss the PROpel trial, which was also a phase 3 trial. This is now switching gears to metastatic CRPC. This was a study of PARP inhibitor Olaparib with abiraterone and prednisone as compared to placebo with abiraterone as frontline therapy for patients with metastatic CRPC. Interestingly here, the study did not make a distinction between the homologous recombination repair mutations or not, and all comers, patients with mCRPC, were included. Retroactively, HRR mutations were tested for, and that data was also reported. So here is the randomized trial initially that served as background for testing this combination in a phase 3 setting. And there was synergy potentially noted with the combination in this phase 2 trial in combination with abiraterone. So the global randomized double-blind phase 3 trial randomized patients to Olaparib plus abiraterone as compared to placebo plus abiraterone with the primary endpoint of radiographic progression-free survival, other secondary endpoints, overall survival, time to subsequent therapy and death, as well as objective response rates, and then HRR mutation testing, which of course is uppermost in our minds with Olaparib being involved in a clinical trial. Prior docetaxel was allowed. However, majority of the patients were fairly untreated. Docetaxel was only allowed in the hormone sensitive stage. So for castrate resistant, almost all of these patients were prior untreated patients. Here is the primary endpoint. RPFS significantly improved with Olaparib addition, 34% risk reduction in progression or death with Olaparib plus abiraterone. Hazard ratio is 0.66. At the 24-month mark, there is about a 17% or so difference in remission rate with the addition of Olaparib to abiraterone. Median RPFS improvement was about 8.2 months improvement with the addition of Olaparib. Blinded review or investigator-initiated review, it did not seem to matter. The results were pretty consistent with radiologic progression-free survival improvement with the combination of abiraterone and Olaparib. Overall survival, fairly immature results. Not enough events have occurred for a complete overall survival analysis. However, so far the trend appears to favor the combination of Olaparib and abiraterone, so more follow-up is needed. Treatment-free survival and PFS2 results also support the longer-term benefit of Olaparib and abiraterone, and objective response rates were also improved with abiraterone therapy, although if you look at the difference, placebo arm 48% response rate and 58.4% with the combination therapy. Measurable disease, of course, is a small proportion of patients. And as you can see here, only about 40% of the patients had measurable disease in this study. So the conclusion of PROpel shows that Olaparib and abiraterone led to a significant and potentially clinically meaningful improvement in radiologic progression-free survival. It was definitely statistically significant, and benefit was observed irrespective of HRR mutation status. However, given the toxicities of Olaparib, especially the increased risk of anemia and cytopenias, clinical use of this combination will probably have to wait for more overall survival benefit and additional follow-up. The next study is the magnitude study, which is results of niraparib with abiraterone and prednisone as frontline therapy in patients with mCRPC with and without homologous recombination repair gene alterations. This study actually had a design where separately patients were stratified into HRR mutations positive versus no HRR mutations. And then patients had a 1:1 randomization to niraparib plus abiraterone versus placebo plus abiraterone. Primary endpoint, pretty similar to the PROpel trial of radiologic progression-free survival, and then similar types of secondary endpoints, overall survival, time to cytotoxic chemotherapy, and time to symptomatic progression. Unlike the PROpel trial, the magnitude trial showed that in the HRR mutation arm, there was clearly a benefit. However, the patients who did not have HRR mutations, the early futility analysis endpoint was met, so no benefit was noted with the addition of PARP inhibitor niraparib to abiraterone and prednisone in the patients who did not have HRR mutations. So as you can see, the curves here pretty much overlap in the patients who had for radiologic PFS with placebo plus abiraterone as compared to niraparib plus abiraterone. So the conclusions of magnitude were that HRR gene alteration patients, definitely there is synergy noted between niraparib and abiraterone prednisone, which confers improved radiologic progression-free survival. However, in the HRR mutation negative patients, no benefit was noted to the addition of PARP inhibition. So given the sort of different conclusions from PROpel versus magnitude trials also gives us more reason to wait for the overall survival follow-up on the PROpel trial before adapting the addition of PARP inhibition with abiraterone and prednisone for all comers in metastatic castrate-resistant prostate cancer. Thank you.